The respiratory assessment is inspection. We're going to look at the thoracic cage. We're going to look at the overall shape of the chest wall, okay? And it should be that their AP, or their antero-posterior, which AP, front to back, should be about a third to half less than if we were to turn them to the side. So right now, okay, I'm facing you dead on, AP, if you will, okay? But if you look at me from the side, do I look fat to you? No. But this depth should be about a third to half that if I was to turn this way, okay? And it is about half. Of course, you know, I prefer it this much too, okay? If it is wider or deeper than that, they probably have what is called a barrel chest, meaning that instead of it being, you know, kind of compressed, it's actually all like circular when you look at it from a dorsal part from the head down, okay? I have a picture of that coming up, all right? We want to make sure that when we are inspecting our patients that they are in a nice relaxed state. So obviously if they're having a work to breathe, we're probably not worried about what their chest looks like right now, right? Again, cough, is it non-productive or productive? COCA, that's going to be a thing that you're going to hear a lot about, okay? Here's an example of what I'm talking about as far as a barrel chest is concerned. So this is what an expected chest should look like as we're looking down, if we were down this way, okay? See that it is shorter than it is wide, okay? A barrel chest is going to be just as wide as it is long, all right? Just like this here. Now, what typically do people who have this, what else do they have? Lung-wise. COPD, more specifically emphysema, okay? Because the body is trying to compensate for that lack of physiologically being able to exchange oxygen and CO2. So it's because those now alveoli are no longer stretchy and elastic, they're just kind of like a dead balloon, okay? It's got to go somewhere, so the body kind of makes up for it.
So in the case of the barrel chest, just so I heard you right, in the case of barrel chest, we would suspect some type of
COPD.
Okay.
Yeah.
And that photo right here also is another example of barrel chest?
Correct.
Okay, just making sure.
Yep. So this is what they might look like from the side, and that's why. Same principle. Okay. Another type of thoracic area deficiency, but alteration you need to be aware of is scoliosis. Okay, we might not think of it as being a big issue. Oh, wait a minute, that's a bone issue, right? It's a lateral curvature of the spine. Why would that be an issue with respiratory?
Constricts the area.
They're not going to be able to take a deep breath on this side, or the affected side of the scoliosis, depending on how severe it is. Okay? So what would you think this person might be more prone to develop? Pneumonia on the left side. Okay? Then we have our lovely friend that we're going to see a lot of, kyphosis. Okay? Now you wouldn't think necessarily that somebody hunched over like this would be an issue for them to breathe, but again, if they can't expand that chest wall with breathing, like this we can breathe no problem, but similar to a patient that's in bed and bent in the wrong spot and they're bent over like this, they can't take a deep enough breath. And so they're gonna have an issue with deep breathing and pneumonia as well. Now we talked earlier about respiratory effort, but you do need to be a little familiar with these different respiratory patterns, okay? So we've talked about, you know, regular versus irregular patterns when we're like palpating a pulse or anything along those lines, but there's a couple of things that your patient's respiratory rate and pattern can tell you, okay? We're very familiar with tachypnea, not tachypnea, right? and bradypnea, that's your fast rate and your slow rate, but then there's a couple other ones. Kussmaul. Kussmaul respirations are typically found in patients who are going through a diabetic crisis. Their blood sugar is super high, okay? And you'll note too that they'll have like a fruity breath with it, okay? But it goes, and it's relatively tachypnic, but it's super deep, followed by little Lamaze breaths, if you will. They're not super deep breaths, okay? Then, and I had students argue with me about this next one, because I say Cheyne-Stokes, but some of them were like, no, it's Cheyenne. Either or, okay? I call it Cheyne-Stokes, because that's how I was taught, okay? But Cheyne-Stokes respiratory rhythm is typically someone who is getting ready to pass away, okay? Because they will have a period of apnea where they're not breathing at all, and then it'll slowly get like longer breath, longer breath, longer breath, longer breath, and then they'll have another apneic period, okay? And at this point, don't worry so much about Biot's respiratory pattern. You'll learn more about that later on in critical care and stuff. That's when their respiratory rhythm's all over the place. Okay. And you guys remember what clubbing is? Nice little, looks like what on their fingertips? I gave you guys an analogy.
Dates.
Almond.
Almonds?
Yeah.
Dates?
That looks like dates.
I gave you guys olives.
Olive, there you go.
No.
Olives
that's a good
on the
one.
tips of their
Yeah.
fingers. Yeah. Okay. Dates. Get from dates. How about next Thursday? All right. Palpation. These are a couple of things that you need to be familiar with as well, okay? So we have tactile fremitus is one. That is when you can actually feel the vibration on the chest wall, okay? Good or bad, do you think? I want everybody to turn to their right, and I want you to, and hopefully everyone's okay with being touched today, okay? But, she already knows, so let me just sit up here. But what I want you to do is find the base of the rib cage on the person to your right, and kind of line up the bottom part of your hand here to the bottom of the rib cage, and just have them say 1, 2, 3. Both sides, so both hands.
Do it.
Okay? Do it? All right, hold on, MJ.
It's like right here.
Oh, I thought to go on the
So,
ninja. Oh.
Guys,
Yeah.
so, I can feel the bottom of her rib cage is right about here. So I'm going to take my hand here and put it right so that this part of my hand is along the base of her rib cage. And take my other hand and do the same on the other side. And then I'll have her say 1, 2, 3. Okay? So, you tell me if you feel anything when you on your partner when you do that. Okay? She's all 1, 2, 3. 1, 2,
All right, MJ.
3. MJ.
Okay, I can kind of feel it. Do it again.
3.
Oh yeah, I can feel a tiny vibration in there.
Oh, because that looks really bad. What do you guys feel? There you go. I don't know. All right. Now turn to your left and do the same thing. So that way people on the end got a chance.
I already did it.
Oh, you already did it on them? Okay, good.
One, two, three. All right, let me try.
I'll say you're a lot in the I know, but like if you're like auscultate for bronchial sounds, like upper, but
Yeah. Because it's right in proximity to here. So here's listening right here, right? And you got your scapula right there, so listening right here, yeah. All right, so how many of you guys were able to actually feel any type of vibrations or anything? Ooh.
If you did or didn't?
Did. Okay, good, good, okay. Anybody not feel anything? You're like, I'm dead inside. Monter's like, that was me. No. It is considered normal to have some tactile fremitus. If they have none or very little, okay, they might have excess air in the lungs or a thickness of the chest wall. So those of us who are a little fluffy, you might have had a hard time palpating on them, okay? Because it's like insulation. I'm up here sweating all the time, okay? If they have a lot of fremitus, like your whole hand, you're feeling the whole thing, very exaggerated, like turn the sound down, okay? That typically means that there's been lung consolidation, meaning that the air or the healthy lung tissue has been replaced with something else, either with fluid or mucus or something like that, okay? We also want to, for those of you that will go on to become NPs, or if that's your desire, we can even measure what is called their chest excursion back here by having them take a nice big, like marking here, and then having them take a deep breath and seeing how much movement there is with that rib moving up as they inflate, okay? Then we have this lovely thing called vocal fremiti, which we just talked about, never mind. I'm not being observed anymore. Woohoo! All right. Now, percussion, I'll go over this more a little bit in lab tomorrow for you guys in group 2, but it is normal to have some resonance, okay? Meaning it should sound dull, kind of like me on a first blind date, okay? Kind of dull.
Oh my god.
Then we have hyperresonance. It's going to be a lower pitched sound, okay? And then we have dullness, which again is a muffled thud. All right. You'll definitely hear dullness over bone, but you shouldn't hear it over normal, healthy lung tissue, okay? All right, auscultation, we're evaluating the presence and quality of normal breath sounds. Even if they are breathing normal, depending on, or expected, depending on where we're auscultating, we should hear a difference. So those 3 breath sounds that I mentioned earlier, anybody remember what those were? Bronchial.
Bronchiovesical.
Bronchiovesicular.
And vesicular.
And vesicular, perfect. Okay, we want to make sure that the person is also breathing through their mouth. It makes it a little easier for us to auscultate and hear the sound of air moving in and out of the lungs, okay? There are 2 phases to breathing. You guys recall what those are? Inspiration and expiration. Inspiration meaning that we're bringing air into the lungs, not that we're inspired to be nurses. That's your inspiration. All right, and then we have expiration when we're breathing air out of our lungs. Okay. We also want to make sure that we are holding our stethoscope directly on the skin. Okay, this is where, especially if you're auscultating on most men, okay, we have what that you ladies typically don't have? Chest hair. Okay, and I have had some patients that literally I could not tell the difference from their beard hair to their body hair. It was like, damn! You can braid that stuff, okay? Now, there's a couple of things you can do so that you can minimize the amount of scratchy sounding stuff that you hear when you auscultate over hair. And typically, it's either wet it down with like a moist or wet washcloth, so that way it's a little slippery and not so dry sounding, okay? Or, what do you think?
Shave.
Clip it, we don't shave anything anymore.
What?
Yep.
This is
We do not shave patients anymore, we clip. Because by using a razor and shaving the body hair, we can cause micro cuts, which again is a portal of entry. Okay? So we want to make sure that we're using the diaphragm and that we're listening for one full respiration in each area that we're auscultating. Okay? Meaning a full breath in and a full breath out. And then move the stethoscope. Full breath in, full breath out. Okay? Undergown, under clothes, all that fun stuff. Do not confuse background noise with lung sound. So what do you think you need to have them do with their remote control? Turn down the volume or turn off the TV. Turn down the radio. Have family if they're really wanting to talk. Not right now, Satan. Okay? And tell the patient to don't talk right now, you just need to listen to your lungs. Okay? Now, there's a specific pattern that you want to utilize. Now, I will say, this one does a zigzag down. It does not matter if you go across like this and down, or if you go, zigzag back and forth. However, the main thing when you are auscultating the lungs is that you are evaluating left and right, or right and left. You're checking for symmetry. That both lung fields, or all lung fields on both sides, have sound and movement. Because if you don't hear anything, and they have absent breath sounds in that side, what do you think that might be related to? Either it's a pneumothorax, that it's being shut down because of that. They've either had a lobe of their lung removed surgically and it's not there anymore, or it's full of fluid and no air is going in and out. So that lung tissue itself is suffocating. Okay. And then of course we're going to do the same on the back. Notice too that we are not auscultating here. Why? Because you cannot hear through bone. You cannot auscultate through bone. Okay? When we are up here and even down here along the chest, we are listening in between the ribs in that area. Okay? Even when we go in to listen to the heart, we're not, and this is next week, but we're not going to listen right here. Granted, that's where our heart is, right? Where do we put our hands when we, do the Pledge of Allegiance though? Okay, but our heart's actually in the center of our chest. That's why we do compressions here and not over here. Okay, I've had so many students be like, well, we put our hands over our heart like this. I'm like, that's symbolic. Okay, that's great. But we would auscultate the heart on either side of the sternum there. Okay, so here's just another view of when you're auscultating the lung fields, where you're actually listening to, based off of that previous diagram. Okay. And what I told group 1 yesterday is I want you to kind of think of the lungs as an upside down tree when it comes to those 3 breath sounds, okay? Because we have bronchial, okay? We have bronchovesicular, which would be like, so this is the branch, or not the branch, excuse me, the trunk of the tree is bronchial. Then where it starts to branch off in this area here would be bronchovesicular. And then everywhere else that you see pink in this example here would be what? Vesicular. So all the leaves of the tree, if you will. Okay? So those would be where your expected respiratory sounds would be. Okay? We talked about these already. Patient's hairy chest, rustling of paper gown or paper drapes. Patient could be shivering if they're cold. Another thing you kind of keep in mind too. Okay, we'll have these here or in our pocket or anything, right? But these are typically made out of what? No, I'm talking about this. Your diaphragm. It could be plastic or metal, okay? And what happens if this isn't up against something warm? It's gonna get nice and cold, and then we take this and we go, what's gonna happen? It's cold, so what should we do first? We don't wanna, okay? Sure, let me just give you my typhoid, okay? But hold it in your palm for just a second or two so that it's not that cold up against their bare skin, okay? A little bit of kindness goes a long way, okay? All right, now as far as your adventitious breath sounds, I would star, circle, highlight, do something to mark this page as being important, okay? Because we have a couple different things that you need to know.
I don't have that on my slide.
You don't have this slide?
No.
Yeah, we do.
Yeah, we do. It just looks different.
Yeah.
Oh, I'm sorry. I thought I updated that. You do have the information, it just does not look like exactly like this. Sorry.
Let's see.
You do need to be familiar with these. Crackles and rails, we really don't talk about rails anymore. We just kind of refer to them as either fine or coarse crackles. Okay? But that sounds like that nice little thing with your hair. You tweak your hair in between your fingers. Okay? Wheezes, they sound like musical tones. Okay? You can have monophonic or you can have polyphonic. Just depends on where the decrease in diameter of the bronchiole is happening. Okay? Then we have bronchi, which are nice little rumbling sounds, typically associated with fluid or like sputum or mucus in the lung tissue or in the alveoli area. A pleural friction rub is just like what it sounds like, or how it's described. It's a rub. And it sounds kind of like if you were to take two leather pieces and rub them together. Okay, that's what it sounds like. You can actually hear that moving. And that's typically related to an inflammation of the viscera, that little area between the lung and the rib cage itself. There could be an infection or anything like that. It's just super irritated and leathery. It's called pleurisy. You guys ever heard of that? I hope.
Yeah.
Okay. Then we have stridor. Anybody who's had a kid with croup or whooping cough, you've heard stridor. Okay. That is that horrible sound that they make. You don't even need a stethoscope to hear it because you can hear it from the doorway. I can't even
Sounds
mimic
like a pig.
It kind of sounds like a pig squealing.
Yeah.
Okay, but it happens with every breath that they take. It's either way, it is an emergency. It is more so an emergency with an adult than a child. Okay, and then of course absent breath sounds typically is because the lung, that portion of the lung, that lobe has collapsed or has been removed. Okay. All right. So the nurse knows that the proper technique for assessing lungs in an adult patient is that auscultation is performed. Now, I went through because I figured, oh, it's a little too easy to have the answer put up right in front of everybody. So let's try a nice little test-taking strategy, if you will, and try to determine what type of answer we can kind of come up with on our own, and then I'll put up the possible answers and see if it's on that list. Okay? So the nurse knows that the proper technique for assessing lungs in an adult patient is that auscultation is performed
Bilateral.
bilaterally, side to side. Okay? Anything else? Let's see. Oh, what's that? That very first one. Do you think that's the right answer?
Definitely A.
It's A.
So for D, by auscultating the anterior and posterior of the right lung first. So that would be listing here, then here, then here, then here. Yeah, no. So which one?
A.
We're gonna go with A. You would be correct. Okay. Now, in lab tomorrow, we will go over, guess that lung sound, so to speak. Okay. Go back.
Yes, please.
But if you're really wanting to take a listen to, and Group 1 already got this web address, but it's called easyauscultation.com. It has a free section in it. You do not need to purchase